All right, thank you very much for the introduction. Thank you everyone for being here. I'm impressed to see so many people still here for the last session. I see a lot of familiar faces, so most of you are my friends just trying to be nice to me, I know, but let's get through MR in bladder cancer. I have no disclosures to make. Just to start by telling you a little bit about bladder cancer and why it's important. I'm delighted to have been invited to talk about this topic. Bladder cancer is usually forgotten about a little bit. Most emphasis is made on prostate cancer these days, and bladder cancer is just not something that features very prominently when it comes to talk and when it comes to research. However, it is relatively common. It's actually the 4th most common cancer in men and the 6th most common cancer in women. The prevalence depends on where you hail from. The most widely prevalent areas in the world are in the Middle East and Europe, where the mortality is twice as much as what it is in Europe and 4 times as much as what it is in the US. The typical bladder cancer patient, when you're thinking about epidemiology, is a man. There's a 4-to-1 male to female ratio who is 60 years or older. Most of these tumors from the histologic perspective are urothelial cancers or transitional cell carcinomas, and these are the ones that are associated with risk factors such as cigarette smoking and occupational exposure as seen in the painting, textile, and rubber tire industries. So you start to get a picture of how your typical bladder cancer patient is not exactly the fittest patient. They tend to be older men who are smokers and have occupational risks. A small but important proportion of bladder cancer, especially those seen in the Middle East and Egypt, have nothing to do with urothelial carcinoma. They're actually related to infection by a parasite, Schistosoma hematobium, and those are the ones that are related to squamous cell histologies and account for about 5% of bladder cancers in general. So having talked a little bit about the epidemiology and why it's important to study bladder cancer, in this talk I want to focus on 3 specific points to discuss and where I feel imaging has a great potential to make an impact in bladder cancer patients. The first one is regarding staging or local staging of bladder cancer, and there's a critical step or a critical change where we go from defining bladder cancers as superficial versus muscle invasive, and I'll dwell into that a little bit later on, but it will define basically how patients are going to be treated primarily. The second topic I'll touch upon briefly is going to be upper tract involvement and how we do that. We're in ISMRM, so we'll talk about MR urography, and I'll give you a few of the alternatives of how to deal with that. And the last part of the talk, I'll focus a little bit on the potential role of MRI for treatment response assessment. And in the context of bladder cancer, the key question is, can we use MR, can we use imaging to predict complete pathologic response to neoadjuvant chemotherapy in patients before they go on to have surgery? So I'll explain a little bit more about what I mean there. But let's start about talking about how you do the T staging. I said the local staging. T staging is one of the most important clinical and imaging factors that are going to help determine what happens to the patient. So in bladder cancer, it's all about how far into the bladder wall has the tumor invaded. So just to show you histologically here, the bladder wall has 4 layers from the inside out: the uroepithelium, the lamina propria, the muscularis propria, and the serosa. Basically, bladder tumors are going to start in the uroepithelium and they're going to grow from the inside out. And each of the T stages are going to represent involvement of each one of these different walls, so that a carcinoma in situ or a TA cancer is going to involve the uroepithelium only. Once you have extension into the lamina propria, you have a T1 tumor. Once you have extension into the muscularis propria, and notice the muscularis propria is actually the thickest layer in the bladder wall, then you're in the presence of a T2 tumor, and you'll see why T2 tumors are specifically important in a moment. And once you have extension to the serosa and beyond, you're in the presence of a T3 tumor. The reason why I say T2 tumors are extremely important, and again, T2 involves the thickest layer of the bladder wall, the muscularis propria, is because once that's involved, we're in the presence of a muscle invasive bladder cancer. These account for about 1/3 of all bladder tumors, and they are usually treated with definitive therapy, most often in the form of radical surgery, can also be done with radiation therapy. If you have a T1 cancer or below, these are the ones that we're going to categorize as superficial bladder cancers. They're the vast majority of bladder tumors, 70 to 80% of them to be precise, and they're the ones that are usually treated with local therapies, most often transurethral resections, alone or in combination with instillation intravesically of BCG or other similar substances. So if we're saying that we're going to base the management on what the pathologic staging is going to be, then it would be a fair question to ask, why would we need imaging? Can't we just do a biopsy, determine what the T stage is, and decide how we're going to treat this patient? The answer is, in some cases, imaging is not needed, but cystoscopy and biopsy do have their limitations, and these are well known. The first one is that, as you can imagine, the bladder wall is a very thin structure. So when you're trying to biopsy a mass that comes right up against the bladder wall, a lot of times you want to be careful that you don't perforate right through it and perforate the bladder wall. What that means is that relatively often when a bladder mass biopsy is performed, when the pathology report comes back, it says the muscularis propria layer was not included in the biopsy specimen. In other words, you biopsied the bladder mass, you got the histology, you got the diagnosis of cancer, but in terms of staging, the needle didn't go deep enough to reach the muscularis propria, and therefore you can't make that key differentiation that we talked about between superficial and deep tumors. And this is just to show a real-life sample. This is just a typical transurethral biopsy report from my institution. They tell us about what the tumor type is, what the histologic grade is, what the pattern of growth is. But when it comes to local invasion, see, this tumor is said to involve the lamina propria, so it's definitely at least a T1 tumor. But when we're trying to decide, is this a muscle invasive tumor, we see this section here saying muscularis propria not identified. So then how is this patient going to be treated? You're still having the same conundrum. You don't know if it's a superficial tumor or it's a muscle invasive tumor, and that's where imaging can have a big role. There's other limitations of the cystoscopy and biopsy approach. Neither of them, for obvious reasons, can tell us anything about extravesical spread, nodal spread, or metastatic disease. The cystoscopy is not perfect, so some tumors may be overlooked when it's performed. And a well-known fact is that perhaps for the same reason that usually urologists are careful not to perforate the bladder wall when performing a biopsy, pathologic upstaging from biopsy to cystectomy is common and occurs in up to 40% of cases. So how does this all look on imaging, on MRI? So the morphologic assessment is performed with T1 and T2 weighted images. This is a T1 weighted image here on your left. It's not very useful for assessment neither of the wall or bladder masses. Basically, the urine is dark and the bladder wall is dark, so you can't really differentiate between them. You have no contrast. When we have T2 weighted images, now the bright urine helps us see much more clearly what the bladder wall looks like. It's seen as a thin, dark T2 signal structure surrounding the entire urine. And basically, most of the signal that we're seeing in the bladder wall is going to come from the thickest layer that we talked about, the muscularis propria. Once we have a tumor, a bladder tumor, it's usually going to be of intermediate T2 signal intensity, and we enter into this concept of trying to decide, is this a superficial tumor or is this a muscle invasive tumor? The way to do it on morphologic T2 weighted images is to identify the low signal intensity of the muscularis propria in the bladder wall and try and see if you can actually follow it all the way around the area where the tumor is located. If you can convince yourself that you can see that uninterrupted low T2 signal intensity from the muscularis propria all the way around the tumor, then that means you're in the context of a superficial bladder tumor. The opposite is also true. If you have an intermediate T2 signal intensity from the tumor that seems to be encroaching or digitating into the muscularis propria and breaking that low T2 signal intensity ring, then you are in the presence of a muscle invasive tumor. Extravesical invasion is usually a little more straightforward to do. This is an anterior tumor, usually typical location for a urachal adenocarcinoma with obvious digitation of soft tissue into the anterior perivesical fat. So this is a T3 tumor. And once you have invasion of the adjacent organs, like in this case a man, so the prostate here is invaded, you're in the presence of a T4 tumor. Now, there are pitfalls for T staging on MRI. It's not always straightforward. By far, the most common problem that we have when we're trying to stage bladder cancers is overstaging. And the overstaging comes from the fact that most of these patients, by the time they reach us, have already had some sort of manipulation done to their bladder, usually in the form of a transurethral resection, and that generates inflammation that is sometimes very difficult to differentiate from tumor on our images. This is just an example here. For all intensive purposes, you see the low signal intensity on T2-weighted images of the muscularis propria. You have intermediate T2 signal intensity here, which looks like tumor. It's even enhancing like tumor, but this patient had had neoadjuvant chemotherapy and subsequently went for surgery, and the pathology showed complete response, so there was no residual tumor. This was all just related to post-resection inflammatory changes. So by now, there's clear data and a lot of data in the literature showing that diffusion-weighted imaging improves our accuracy for T staging on MR. This is just an example from one of the early papers. The principle is that, number one, the muscle-invasive tumors are going to have a higher extent of diffusion restriction, but perhaps more importantly, when evaluating these images qualitatively, is the fact that the non-muscle invasive or the superficial tumors tend to have a smooth outline, as we see on the image from the patient on the top here, whereas on this other patient at the bottom, the outline is more spiculated or irregular, and that's a very strong sign, an indicator that this is a muscle-invasive disease. As I said, one of the early papers, 2009, showing improvement in accuracy from 79 to 96% with implementing diffusion, and a modest further increase when using qualitative evaluation of contrast enhanced sequences in addition. Since then, there's been a number of publications. This table here is from a paper published in 2014. All the papers show more or less the same. Diffusion definitely helps and demonstrates incremental value compared to T2-weighted images alone. We are already seeing how these papers introduce the concept that quantification of the extent of diffusion restriction may also be relevant, and I'll talk to you a little bit more about that in just a moment. This other meta-analysis that I've cited here at the bottom looked at, I think, 28 papers or something like that, and overall a pooled sensitivity of 0.85, specificity of 0.90, and AUC of 0.92 was found for differentiating muscle versus non-muscle invasive bladder cancer. So as I mentioned earlier, quantitative diffusion has also been explored. Significant differences have been shown in ADCs between tumors of different stages and tumors of low grade versus high grade. Note that one of the main problems when it comes to trying to apply these concepts into practice is that even though there's statistically significant difference in the means of the ADCs between the different stages and grades, there's still a lot of overlap, so that it's at this stage impossible to establish a threshold above which or below which you can call it one stage or another. So significant trends, significant associations, but still quite some way to go before this can be used routinely for clinical purposes. Some hope that applying a diffusion kurtosis model for the diffusion data could help reduce a little bit of that overlap. This is a paper published last year, and basically it showed, as had been found before, that low ADC is seen in bladder cancer compared to the normal bladder. In addition, the two kurtosis parameters that were evaluated, the revisionary diffusion coefficient and the deviation from the Gaussian distribution, were significantly different as well between bladder cancer and normal bladder. However, the hope, and all of these parameters were also able to differentiate low versus high-grade tumors. However, the hope that the DKI was going to be better than the simple ADC metric didn't materialize. Unfortunately, as reported in this paper, they weren't significantly different, neither for differentiating cancer from normal bladder wall or for differentiating cancer from high-grade tumors. So we know diffusion helps, especially qualitative assessment. Is there a role for contrast? This is from the same review paper, 2014, summarizing most of the literature that has been out there about the use of contrast in bladder cancer. Some of the very early literature, 1996, was already talking about important issues such as the timing of the contrast enhancement of the bladder tumors compared to the bladder wall. And this paper, for example, showed that the bladder cancer enhances approximately, on average, 4 seconds earlier than post-biopsy tissue. So maybe some opportunity to exploit the concepts under dynamic contrast-enhanced MRI to our advantage. For the most part, if there is no inflammation, if there's been no transurethral resection, contrast is actually very good. It does improve the accuracy compared to T2. The jury is still out there with regards to does it actually improve the accuracy when you take into consideration the information from T2 and diffusion combined. There's very few papers that have actually tried to address or evaluate this issue. This paper by Gupta et al. Published last year did a stage-by-stage analysis and basically reported very similar accuracies and correlations between the imaging findings and the pathology for diffusion and DCE-MRI. And in fact, 83% of patients had absolute agreement between the two sequences. So no hint here that one or the other is going to be best. This other paper by Zhu, published in 2014, looked at the ADC from the diffusion and the washout rate from the DCE-MRI, found them both to be associated with bladder cancer aggressiveness. But again, if you focus on this and remember what I showed 2 slides ago, you have a similar problem. So there's a significant differences in the mean, but the box and whisker plots show that there is a lot of overlap between the parameters. So still at this stage, neither with diffusion or with DCE, you can actually establish a threshold for any of these parameters to try and decide about a stage or decide about a grade. I wanted to mention some other novel approaches that have been reported. For example, this paper published in PLOS ONE in 2014 found that ADC, and this is just the standard mono-exponential mean ADC value, was not only associated with T stage and with grade of aggressiveness, but also with markers of proliferation or proliferative activity, such as P53, P21, and Ki67. And actually, on multivariate analysis, only the ADC and the P53 were independent predictors of muscle-invasive disease. This other paper from the NYU group, published last year, took an approach of doing a whole lesion analysis. Up until now, every paper I've discussed here has focused on a single slice ROI measurement on a representative area of the tumor. This paper tried to analyze the entire lesion, so put a volume of interest and ROI over every slice where the tumor was seen. As in all the other papers, it found that ADC was lower in muscle-invasive tumors. The kurtosis, and this is not the kurtosis from DKI, it's the kurtosis derived from the histogram analysis, was lower in patients who had nodal metastasis, but was not in itself associated with the T stage. So the conclusion of that paper was that maybe you can use both. You can use the ADC value for its association with the T stage and use some of these more fancy histogram volume-derived parameters to establish extent of disease. So the second and third points I'm going to talk about will be quicker. The second one is regarding upper tract involvement in bladder cancer, very important concept. It happens in about 4 to 5% of patients with bladder cancer. The problem is it can happen at any time. It can happen at the time of diagnosis, at the time of presentation. It can happen during initial treatment, after initial treatment, any time during follow-up. So it's a big deal, first of all, to continuously have to evaluate this, and second of all, to deal with it if something is identified. So traditionally, the thought is that CTU and MR urography are equivalent somehow from the diagnostic perspective. Most times CTU is performed in clinical practice, but more and more MR urography is growing in popularity and is obviously also an alternative when there's allergies to iodine contrast from the CT. However, some recent papers, including this one published last year, found that actually MRU has better sensitivity than that CT urography, but still imaging cannot replace the approach of cystoscopy and biopsies, given that there were a number of tumors that were seen on cystoscopy that weren't seen neither with MR or CTU. So it still remains sort of staging mechanism rather than a primary diagnostic. With MRU, we take advantage of the different methods for evaluating the renal collecting systems and ureters that MR affords, such as evaluating through static fluid techniques that can be various forms of T2-weighted images, including this 3D respiratory triggered heavily T2-weighted FSC sequence that David showed quite elegantly in the talk this morning. It's akin to the MRCP-like sequences and very good for delineating the ureters without having to use intravenous contrast. The other obvious option is the use of contrast and excretory urography, deemed excretory urography because of the underlying principle of filling the pelvic calyceal systems in ureters and evaluating for the presence of filling defects indicative of tumor. But actually, once you give the contrast, you can take the opportunity to evaluate the kidneys in the parenchymal phase as well, about 80 seconds after administration, and that gives you a chance to see flat tumors that present themselves as urothelial wall enhancement or tiny nodules that have enhancement. And obviously the excretory phase, the literature reports variable timings for the excretory phase ranging from 5 to 12 minutes, but usually what we're looking for there are filling defects, and these are just two examples of essentially what we're looking at in the lower pole calyx in this patient and in the left upper pole calyx in this other patient. So MR urography has its limitations. Most of them are related to the difficulties with the technique and the experience that the group needs to have in order to get good quality images. There are well-known artifacts associated with MRU, most of which are associated with MR in the abdomen and pelvis in general, motion, the presence of calcification not dealt very well with, artifacts from surgical clips and flow-related artifacts, especially in those heavily T2-weighted 3D images that we see. Now, one of the things that has traditionally hampered a little bit the use of MRU has been that if you need to stage the bladder cancer and you need to image the upper tracts, it's been a little difficult to negotiate how you're going to do to evaluate the contrast enhancement of the bladder, and at the same time, how are you going to evaluate the upper tract? So the timing of the contrast and the type of the sequence doesn't quite work out most of the time, and usually that led to two separate examinations, and usually that was a bit of a problem. This paper was very interesting here, published very recently by, again, our group at NYU here. We have Hirsch in the audience, prior speaker. Simultaneous high temporal resolution quantitative perfusion imaging of the bladder together with conventional multi-phase urography. So this essentially solves that issue we just talked about. Essentially, they did a golden angle radial sparse parallel sequence, a GRASP sequence, where the raw K-space data is acquired continuously. So there's no need to have a predetermined temporal resolution, and then basically the data can be reconstructed retrospectively at variable temporal resolutions of interest to simultaneously evaluate the primary bladder tumor and the upper tracts. So this is an example taken from the paper. Very nice. I believe the temporal resolution was about 2 seconds or so, but you can get the picture of the time to signal intensity change curves between the bladder tumors and the blood pool. And you can make quantitative DCE measurements and get differences here, for example, the K-trans differences between the normal bladder and the bladder tumors. And you can get different post-contrast phases of the kidneys and the upper tract. You have an excretory phase here on the right-hand side and some earlier phases of enhancement before that. So final point, diffusion to predict pathologic response to chemoradiation. Why do I even think that that's important? Why did I include it as one of the 3 points that I had to choose about bladder cancer? Number one, in bladder cancer, it's a fact that neoadjuvant chemoradiation has been shown to have a survival advantage. So theoretically, you want as many patients to undergo neoadjuvant chemoradiation prior to surgery as possible. However, the chemotherapy is very intensive. It's debilitating. Remember our typical bladder cancer old, smoking man is not very fit to tolerate the chemo and the surgery. And the problem is, right now, every patient who has neoadjuvant chemo-RT will go on to have surgery, regardless of whether there's pathologic response in the bladder or not. And that's because we don't have accurate enough non-invasive techniques to define the response to chemotherapy. So if we were to develop something that's sufficiently accurate to be used, it is possible that in the near future, some of the patients who have neoadjuvant chemotherapy may not need subsequent surgery, as in the case in other tumors already, such as rectal cancer. So encouraging results published to date. This is a 2012 paper here showing significant differences in mean ADC values between chemoradiation sensitive patients and chemoradiation resistant patients. Not a lot of overlap in the box and whisker plots, so maybe something that could be used moving forward. This one is also very interesting, published JMRI last year. Instead of DWI, this paper used DCE. And basically, it used a clustering algorithm, a k-means clustering algorithm, to separate out within the tumors areas that had variable combinations of these two DCE parameters, the KEP and the signal intensity amplitude. So a cluster 1 with low both parameters, cluster 2, one parameter low, one parameter high, and cluster 3 vice versa. And essentially what this helps do is tap into the concept of tumor heterogeneity. It doesn't have to be that the whole tumor behaves in the same way, and there may be that there is a cluster that behaves in a particular way that's going to define how the tumor is going to change and evolve. In this particular case, all the 3 clusters that were determined were associated with chemo response. However, one of the clusters, cluster number 2, had the highest area of the curve, 0.96 for defining and predicting the presence of response. This is an example of how they did that. You can see the tumor with the variable colors representing different clusters. You can see the cluster representation on the graph here, and you can see the association between the clusters and the chemotherapy response here. So interesting concept. Maybe the answer lies here. Maybe when we try and make these metrics that are basically averaging the findings of DCE or diffusion throughout the whole tumor, we're losing out on this heterogeneity concept, which is a known feature both from the pathologic perspective, genomic perspective, from many other tumor biology related perspectives. So maybe that is the way that we should try and think about our imaging moving forward. So I finished with this slide, PET-MR, simultaneous with this session. There's been another session all day that's been talking about this. Obviously, we're in ISMRM, and this is an MR bladder talk, so I've focused on the use of MR in bladder cancer. However, there is plenty of literature that talks about the usefulness of PET-CT in bladder cancer for exactly the same purposes that I focus my MR bladder talk here. Most of the literature is about the standard fluorodeoxyglucose or FDG PET, but there's also some literature on more novel tracers, choline and acetate. It may be that in the future, PET-MR can play a bigger role in bladder cancer as well. So far, the only paper I could find in the literature is a focus on the technical component of the PET-MR acquisition, something that is indeed very relevant, especially for bladder cancer, and is not only relevant to PET-MR, it's probably relevant to MR per se. This paper was trying to think about sequential versus simultaneous acquisition of the PET and the MR data. And if you think about bladder cancer, and if you think about the bladder lumen constantly filling as we're doing the exam, even if we're doing just MR, it means that what we're seeing when we're doing the beginning of the exam may vary slightly compared to what we do later in the exam. And especially for acquisitions that last a few minutes, it means that the tumors and the bladder wall and all the structures in the pelvis are going to be moving along the time. And that has to be dealt with because it causes specific difficulties when it comes time to try and quantify and make any specific measurements. This is an obvious example. You see the difference in the registration of the PET data on the background in the orange and the MR data when the images were acquired sequentially, first the PET and then the MR, and you see how they fit much nicer when the images are acquired simultaneously. So it makes sense, but something important to keep in mind. So with that, I thank you and open the floor for questions or comments. Thank you very much.